From Redox and Healthcare Strategy Bullpen, welcome to Diagnosing Healthtech.
Good afternoon. Hi, I'm Jeff Englander. I'm the founder and principal of Healthcare Strategy Bullpen, and we are pleased to welcome you to another episode of Diagnosing Healthtech today. Today's a special episode. We have the new CEO of our sponsor, Redox, Mr. Trip Hofer, coming in. Prior to Redox, Trip was actually, let me back up. Good morning, good afternoon, wherever you are, Trip.
Right now, it's afternoon where I am. So good afternoon to you, Jeff. Nice to see you again.
Yeah, I believe you're up in Boston, and if you can help a little with the Red Sox bullpen, we would appreciate that. So prior to joining Redox, Trip was a venture partner at 406 Ventures. Prior to 406, he was the CEO of Optum Behavioral Solutions and the CEO of virtual mental health company that most of you, I'm sure, have heard of, which was which was sold to Optum in 2020. And prior to Optum, Trip was with CVS, where he was the general manager of NovoLogix, where he dealt with claims and prior auth, and also the VP of product development for CVS Specialty. So welcome, Trip.
How are you?
I am great. As I said, if we could just, maybe the Celtics too, get a little, hoping for the Bruins tonight. As you can tell, born and raised up in Boston. So hoping for all my Boston sports teams.
Yeah, no, it's topical right now with both. So unfortunately, we're staring two losses in a row. So the Celtics lost last night, and the Bruins lost the night before. Both lackluster performances. So the weekend should be very interesting.
Yeah, it'll hopefully be a weekend full of some Boston wins, and congratulations to you Ranger fans out there. So Trip, let's start this off. When I was at a conference recently where you presented, and you stated that Redox sells pipes. Can you kind of elaborate a little bit on that and what you meant by that?
Yeah. Let me start, if you don't mind, Jeff, and like sort of how I got here, right? And
please.
Why the pipes were, I think, to me, I always, when I talk about the businesses that I'm part of, I think about how I would explain this to my neighbor, which my neighbors tend to change, but so it's not one person all the time, but how would you explain this to or a family member or someone so that they could get their head around it, who's not really familiar with healthcare. But as you mentioned, I was coming out of Optum, where we had sold a company in behavioral health to Optum. Then I was running Optum Behavioral Health, and I was fortunate enough to hook back up with someone I'd worked with before at 406 Ventures, Liam Donahue, who sort of asked me what I wanted to do next with my life, and we came to an agreement that I would work as a venture partner for 406. So I'm still doing that, but primarily spend my time as a CEO of an organization within their portfolio. And I really didn't know what that was going to be, to be honest with you. And very quickly, what happened was the CEO of the group, Luke Bonney, who's and founder, by the way, one of the three founders of Redox, and just an amazing individual, raised his hand and said he'd been doing this for a while. He has 3 young kids. He still is a part of Redox, and I use him quite frequently and really value his input on the industry and the company. But he's like, listen, Trip, I want to get the gas back in the tank, if you will, and go potentially do some other things. Would you, this might be interesting for you to come aboard as the CEO of Redox. And I didn't really know a lot about data interoperability, to be honest with you. What I knew about it was what was not happening effectively. And I ran into this in my other companies, which is this promise of sharing data with the outcome to be better patient care, right? And the majority of this is between the provider and the entities of which are providing care outside of that provider fabric, ecosystem. And so I knew a little bit about it, and we had challenges even when I was at Optum. And those of you who know Optum well know that Optum owns provider assets, and even in those instances where we own the provider, getting data into and out of an EMR, for example, or into and out of a care plan were really difficult. And so when Redox popped up as an opportunity, it was really interesting for me, because that was I think an area where a lot of focus has happened, but not a lot of outcome to the extent that we all need it to happen. So that's a phenomena. Just what was going on in the industry. The other thing that was happening or continued to happen was value-based care, which we'll get into a little bit, I think. But that is the future of payment in healthcare, is value-based, moving away from fee-for-service to value-based care payments. We all know that. And as I talked to the board and others about why I thought this job was so interesting, it really focused first and foremost on value-based care and enabling value-based care. And so that was my going in mantra, if you will, was I think Redux has a way to really influence value-based care arrangements by delivering data in a way that it can be consumed. Then what also happened very quickly as I took the role is I realized kind of in like a duh moment, like how much AI and machine learning is impacting everything that we're doing now in healthcare. And you saw this, Jeff, at a recent conference that you and I both attended. You can't go to a conference right now and not have someone talk about AI, right? It's just going to happen. And even in a typical week conversation, someone mentions it. And there's so much money being poured into this space, what I would call AI and machine learning. And what people are beginning to slowly realize is that these tools and these approaches are fantastic and can be really, really impactful, but you need the data. And so when we talk about pipes and the analogy that I use, what we do at Redox is we build pipes, and we build pipes that connect A to B. We started, as I mentioned, Luke and the other founders, really connecting digital health vendors to EMRs, so writing and reading from an EMR. But the organization has expanded really within healthcare to attach from A to B and move that data from wherever it might be, whether it would be from a health plan into a cloud environment, whether it be from an EMR to an EMR, whether it be from a digital health vendor into a cloud, or you name it. It's just how do you build the pipes that move that data in such a way where the data is then to be consumed as it needs to be consumed to lead to an outcome. It's really what it's all about. The reality, though, as you know and others know, in healthcare, which is different than like, let's say, fintech or others, is healthcare data is messy. It just is messy from basically the time that is incepted, if you will. So when you do a provider does a first diagnosis, that could be incorrect, for example. Yet that data starts to flow, but it also changes rapidly. And so you can't just build a pipe, you have to maintain a pipe. And so it's building the pipe that do the connections, but also maintaining that pipe and enhancing the pipe such that it's able to be, if you will, flexible enough to ensure that the data continues to flow in a way that accounts for the fact that it's messy and it needs to be continuously massaged and enhanced.
Yeah, no, that's a perfect point. And I think the analogy really about it's almost the not just the pipes, which other people, but the connections and the kind of, as we talked about in the prep call, I think of it as like an old house where you've got different things patched, and you've got different size pipes and different things connecting, and you almost sell the connections to make all the pipes flow together is the way I think of it.
That's better analogy than mine. I might start using that, by the way. I'm going to use that and pretend it's mine.
Well, I don't think it's patented yet, so I think we can go with that. So let's talk about, you mentioned, everybody in the industry knows that we're moving from fee-for-service to value-based care. And value-based care is really empowered by data. And how does Redox help propel value-based care and get providers and payers more comfortable with risk?
Yeah. So, as mentioned, at the end of the day, well, not the end of the day, the most fundamental part of value-based arrangements is you have to have the data in order to establish baselines, and then understand, based upon that baseline, what impact you have had, or the entity that's at risk has had, in order to make a value-based arrangement or a payment. That's just how it works, right? And you agree to initially a set of metrics that will be measured and things that you will do in order to then see the value and pay based upon the value and not just on episode. So again, as you know, but others might be listening to this and not as deep in healthcare as you or I. Today, you're based upon fee-for-service, as you provide a service and you get paid, versus you produce value and there's an outcome there and you get paid based upon that value or that outcome. That doesn't work if you don't have data, plain and simple. And data that can be consumed in such a way that makes it easy to establish baselines and then understand how you performed against those baselines. And there's so many examples of this, right? And so I'll give you one that I just heard the other day in the value-based arrangement. I was talking to a hospital system that was interacting with a health plan, and they were basically, the way that they were establishing the contractual relationship was by sending FTP and Excel spreadsheets back and forth to each other. And he's like, Trip, the number of hours we spent just debating if we had the right file. And then when we got the file, like it was manipulated and someone moved a column, and then like the whole thing. So he's like, we were spending hours just on like, what is the denominator? And he's like, if you think about like how much wasted time that is on trying to, come up with the right data to measure versus like getting in a format that can be easily digested And again, I give that example because it's so basic, right? I mean, we're dealing with some basic stuff here, but getting that in a way that can be used in such a way that can be consumed by both entities to know sort of where they stand today and where they stand in the future. And this really is, again, it's at the end of the day, it's about improving care. And I think we talk about this idea of gaps in care, which is what value-based arrangements are all about, right? So whether you're a diabetic, or you can name whatever the challenge might be for you on a health perspective, but you're trying to have the provider, you and the provider as a partnership, patient provider, working together so that you're more healthy, and that's a good outcome. And you have to measure that. And today there was a stat you and I were talking about before, right, released by the CDC, that if you were able to close those care gaps, you could save on a yearly basis, I think it was 100,000 lives a year, up to $150 billion of healthcare spend. And that later one, by the way, I'm not minimizing 100,000 lives. That's incredible. Think about that spend. $150 billion by just decreasing gaps in care. That's a huge number, but you can't do any of that if you are not enabled by the data. And that's the biggest thing I think it's like table stakes, right? It's like get the data to the right people so they can start to do something with it that can get after those two numbers I just gave you, that 100,000 lives and that $150 billion of spend.
Yeah, no, I think that's absolutely true. And I just to clarify one thing, it's 100,000 lives a year, and I think it was a total of 150 billion in spend. But certainly not to minimize the 100,000 lives, but it's all too common that you have things going on like you do at the hospital, where you're dealing in spreadsheets, or you're dealing in FTP files, or sometimes even worse, you're dealing in PDFs that are getting uploaded and have to be scanned, for data. So, part of first, you want to close those gaps in care. You want to give better treatment for chronic conditions, preventive disease. But part of what you have to do is you have to segment the people that need that and identify those patients. So how do you help the companies do that? And how to and it's not just you, but the other companies, but we're focusing on you guys in particular. How does Redox help your clients, in particular their providers and payers, look at identifying and segmenting those high-risk patients that account for a disproportionate amount of care?
Yeah, so I think when you think about that specific question, I think about it as sort of like we are an enabler of that type of activity. So what we were starting to do at Redox is we're starting to talk about entities. This is not just say, here's a product off the shelf, you go and take it and plug it in. You're trying to solve a use case, basically, is how we refer to it, right? And the use cases can be all types of different types of use cases, or it could be anywhere from prior auth to what you're talking about. It could be gaps in care. It could be all kinds of different things that an entity is trying to solve. And what reason it's really important to look at it from a use case perspective is, even in your question, you start talking about segmentation of high-risk individuals. That looks very different, for example, in a diabetic population versus a mental health population versus a pediatric population. So you have to understand, what do you need? And by the way, it's really interesting. Again, another conversation I've had in the past, which is you go to, let's say, a health system or provider system and say, what do you need? And the typical answer is they say everything. And you're like, well, you don't need everything, right? And by the way, you can't consume everything. I mean, that's a lot of data. So we have to sit down and understand, what do you need? How often do you need it? Et cetera. And then sort of define that use case, and then work to get that data over to the entity for it to be consumed in that model. We don't build the model, right? We enable the model. So think about, again, like we are an enabling force I talked about AI, but it could be something you're talking about. Models, there are a lot of really great models that have been built that can identify really well now, by the way, those members that need care now. They can't do that, though, if they don't have the data that can be consumed. So we're enabling that, via these pipes that I'm talking about. That's how we fit into that ecosystem that you just described, is by enabling those models. But we have to understand what they need and then getting that data on a very timely basis, by the way, because it can't wait. You can't say, oh, get it, we'll do it every once a week. It's got to be real time,
Yeah.
And by the way, the other big thing is, if you are doing something, and we talked about this in previous roles I was in, we can send the data out, but we also want the data to come back in. So if you send data from an EMR to someone who then is doing identification, let's just say, or whatever, the individual, whatever comes of that, whatever the outcomes are, that data has to be brought back into the EMR, for example, for the provider to understand. So it's important to send it out and also get it back. Just as important, right? To read, we call that reading and writing. We want to be able to read from you, but write back to the EMR so that individuals know what's happened so that they can provide holistic care. So
yeah, and that's, as you know, I teach at NYU and I teach a course on this. And one of the things that really is a key enabler of value-based care is that feedback loop,
exactly.
is pulling the data out, identifying those patients, and then putting it back in and saying this person needs to have a endocrinologist visit every 6 weeks, and this person needs to have one every 2 weeks, and this person's A1C is X, and this person's A1C is Y, and so there's a different care plan. Let's move to something that kind of gets under everybody's skin a little bit, and it seems to be getting better. You worked in it in your prior life, no pun intended, but prior auth. How do there's a bunch of different things out there. How do you guys fit into that and help solve that problem, which is a bottleneck?
Yeah, I think it's a great question, and prior auth, I think, is the bane of everyone's existence, right? And so, the amount of time and energy that is spent by whether you're a provider group or whether you're a health system, and in dealing with prior authorization, it's a necessarily evil, is the way I kind of talk about it before. I mean, if everyone was an extremely good actor in healthcare, you wouldn't necessarily need prior auth, but that's not the case. And sometimes it's not malicious. Sometimes like people just don't appreciate that, and so you need to look at this stuff and authorize in such a way. And if you assume everyone has good intention, that's exactly what it is. But I don't think there's a single provider group out there that would tell you that they like prior authorization. And when I was in my health plan role, leading behavioral health, I used to, when I would speak, I would always be able to really quickly point out the doctors in the room, and I'd be like, okay, they're going to ask me about prior auth. I know it. Right. And again, for those of you who don't appreciate, and I'll tell the story, it was a provider group down in Washington. I'm down in Florida, excuse me. Very well-known provider group. I can tell you who it was, but a very well-known brand provider group. And this individual stood up and said, listen, when I think about my clinic that I run, about 50% of the total time of the clinic is spent in submitting information for prior auth. Think about that.
Staggering number.
He's like, it's crushing me. Right now, we also talk about the other 50% and how to work on that as well, which was a really interesting conversation. But even take that 50% down to 30 or 20 or whatever. And then, of course, and it's true. He's like, the number of pages I have to fax over, it's embarrassing. Like, and again, like we always joke about healthcare is the only industry that uses a fax machine. Most young adults now wouldn't even know how to operate a fax machine unless you work at a hospital where you have to know how to learn it, use it. He was describing faxing, not like I send a fax over, Trip. No, 150, 200 pages per prior authorization to fax over to get this looked at. And by the way, like you're now going to assume, again, this is really basic stuff, right? But you assume that those 150 pages are received and they all print. Right? They print. There's ink in the fax. I mean, again, this is getting kind of absurd, but
they don't fall out, and they don't fall out of the fax machine, and they're not numbered. Yeah,
exactly right. I mean, again, it's like this trivial stuff that is real in healthcare. That is real. This is how it happens. And so, again, our ability to to work with entities, because by the way, there's a lot of entities that are out there that are trying to better automate this process. There are a lot of things that they're doing. But even if you think about that, like automating faxes, right? How do you take that information and get into a digestible and consumable format that then can be used by an entity to expedite the PA process, which again, I just gave you some examples of how onerous it is. And it's not only onerous in terms of people and time, but just think about the mentality of like, you got to go through this thing and you got to consistently go back and you got to explain why you're doing this thing. And you got a health plan who's trying to understand it. And they're saying it's denied and you're a provider and you're upset. And there's this caustic relationship. The whole thing isn't pretty. And so our ability, again, to basically enable prior authorization process, the automation thereof, to expedite it and become more, not only to be more efficient, but more effective, right? So what we would always consistently talk about at Optum, and people may not believe this or not, but we wanted to not have prior authorization. We're like, okay, there are instances where we don't have to prior auth things anymore. I mean, wasn't something that we were excited to do. But the only way to do that would be to have like usable data so that we would have enough to say, okay, this doesn't need to have a prior authorization, this diagnosis, for example, or whatever this might be. We can move this through more rapidly because we do want to have a better provider experience so we can have a better member experience. That is the goal. And so that, again, it can only be enabled by data that comes from point A to point B. And that's what we also work with. That's a use case. How do we help the prior authorization process be more efficient or effective. I will say though, Jeff, and you know this, I wish it was a process that we could implement across the country in every health plan system and every provider group across the country. Not going to happen. That's another thing. Like this, why it's use case by provider system and by entity of which is doing the prior auth, because they are unique. It's just the way that healthcare is. And so you have to understand that use case, make sure the pipe is built in such a way that can be enabled on both ends, be receiving and writing and receiving, if you will, that data. And then the technology is reusable, by the way. That's the good part about what we do at Redux. It's reusable technology. We have to make sure we get the inputs right and the outputs.
Yeah. Let me ask you, and you talked about data and getting it in the right place. And so we referred to AI, and you and I both met for the first time at HIMSS, and you could not walk 10 feet without everything, including the, food station being AI enabled somehow. How does, talk about, all of these visions of what AI can do and predictive analytics and population health. How does better data management and improving the quality of data feed into that and empower those use cases?
Yeah, and you've probably figured out now. I like to tell stories as I provide answers because I think it makes it more real. So I'll talk about another provider system I was at. This was last month, and the entire use case for them was getting information from the EMR into the cloud environment that could then be used not only for retrospective analytics, which is what to be honest, which is what I thought it was going to be. So, for example, you could tell, be it the data, like what you were doing in post-hospital discharge, how long someone was in the hospital for, and what lengths of stay, like how were those tracking? Did it go up? Did it go down? Why? All that kind of stuff. So that's what I mean by retrospective analysis. But it was also being used, which I was actually sort of excited with, by really influencing the workflow on the spot. Like, so in this instance, it was an ICU and helping the nurses be more efficient and effective with their care of the patient by basically taking the data, being able to run some analytics on it, using AI to run analytics on it, and being able to suggest to that nurse at that point in time of care what he or she should do to better support the patient. And that's really sort of the learning of the AI in this instance with this ICU. So that's great. And you can talk about it all the time, but let's now get to the reality of what happens, okay, in these ICUs, right? So in this instance, right, the machine, sort of the EMR could have latency. In this instance, it was a dashboard. The dashboard can have latency, and we all know what latency means, so that thing starts spinning, right?
Yeah.
Now, for a nurse in an ICU, let me tell you what that means. That means they go to paper.
Oh.
Right? They literally they can't wait. They get frustrated and they start to do things in paper. So that, first of all, then you're in a lot of trouble. Not a lot of trouble the patient-wise, but like they take phenomenal care of the patient. It's just when you're talking now about, because you want to have a whole data picture, right, in order to get it through those models to help be more efficient, more effective with the care. But now you're missing pieces of data because it hasn't been written down, right? So that's a problem. The way that the EMRs are sometimes built in order to, it was phenomenal to me. They were saying, well, we use this as a learning experience because one of the nurses didn't click something they needed to do to inform the data element. It was 7 clicks into the EMR. And so that nurse had to know how to click to get to the point where they clicked the data field in order to populate to get that data to a point where then it would inform the machine, the AI learning. So I tell you that because like there are so many amazing possibilities. It really hit me in this environment where like I get energized when I hear, for example, the CEO of Google talk about the future of AI, what it can do to healthcare. And I'm using that as an example. And there's so many great brains that are out there talking about this. But if the data isn't enabled, right, the workflow isn't enabled in such a way that you can get that into the AI environment for it to be consumed, like it just isn't going to happen. And those are the realities that we work with a whole bunch of different people to say, okay, how do we ensure we get the right data into these congestible formats? So when I say the right data, all the data as much as we can in these formats in a standardized way, in an enriched and enhanced way, which is what a lot of what you work on too, in order for it to be consumed. And so think about it this way too. Another interesting thing, Jeff, is like even something as basic as like, let's say for me, Trip Hofer, I identify as a male, right? And so, but in a data feed, I can come across as an M, as a male, M-A-L-E, as a hyphen, as an asterisk, as a 0. I mean, it's endless, right?
Yeah.
And so if you pump all that data over to a machine, to AI, it's like what? So you have to make sure that's normalized and enhanced in such a way where it's being consumed as I'll make it up as an M, right? So that data comes, how do you uniquely identify that Trip is basically in this file, it's Trip here, in this file, because I have a bunch of different names. And so right. So I could come across as CJ as one of my other names.
Right.
Right. So how do you do all that stuff? And so even that, there's all these particularities of the data that you have to work with. And we have partnerships that help do that. But again, to get that into the AI environment so that the real magic can happen, by the way, that's what we're trying to enable, is that real magic that can then influence better patient care.
Yeah, and just to elaborate on your point, we did a blog, I think about a year ago, talking about Cleveland Clinic, and they were trying to look at prescription patterns, and they didn't have 10% of the prescriptions in the system, and you can't run AI analysis on that or train a model if you don't have that data.
Yeah.
So
exactly.
Absolutely the case. Well, let me ask you this. You and I have both been at this a little while. What is the area that we haven't touched on that you've been out on the road, as I know, talking to clients, and what is the area that we haven't touched on that you think is something that people are going to do a lot more with that we really haven't talked about?
So I think it's hit the news a lot, and I think what's going to be really interesting over the coming months and quarters is just the reality of data security in our world today. Yeah. We all know what happened with Change Healthcare. Now, a couple of days ago, Ascension just got hit. Right, that hit the news. These are going to come. I was on a call the other day, and I always like the calls where someone says, like, if you only hear one thing from this call, it will be this. And this is the one thing I heard from the call. At this point, it's not a question of if, it's a question of when your healthcare system is going to get hacked. Like, it is going to happen, period. And so this idea of, it's great to have the data in the pipes, but then you start to talk about security and security protocol. But even if you go back to some of these health systems and other organizations, they don't necessarily even know where their data is, like what's going out today and how it's being consumed. And so there's going to be a lot of focus on where is my data? How do I make sure the security is where it needs to be so that I can move it and pass it? And that all has to happen, right? What I fear is that slows down. And by the way, in some cases appropriately, but that it slows down everything that we just talked about. Because you need to figure out what is going out of my system and how is it going out and who's consuming it, and it turns into a year process of doing investigation, security protocol review, and all that stuff. Which, by the way, I'm not saying doesn't need to happen, but there are impacts to that, and some might say that's a necessary impact, and I agree. We need to ensure the data it must be secure, but I'm so eager, right, to continue to move health that I would hate to see. Again, especially these big organizations where you start to have months and months and months and months of reviews, and you just sort of get caught up in that bureaucracy. Because again, we live in a world today where our health information from big systems, not even big systems, is going to get hacked. I mean, it's just going to happen.
Yeah.
And so, how do we think about that as we continue to try and use data in a way that can, again, inform health and provide better outcomes?
Yeah, for those of you who haven't were not on the show last week or 2 weeks ago, we had Mike Sankey from one of your partners, Databricks, on, and he was talking about just that: data governance, inventorying data, maintaining data integrity, maintaining updates, and all of those things. And I know you're going to do a piece on that, meaning Redox. Anything else you wanted to add before we thank you for your time, Trip?
No, it's funny. I will close with this, and I joke that, and you were at this conference where I joked about it. When I describe Redux and say data interoperability, I typically don't even get through that second word before people start to gloss over and fall asleep, right? And it's not a sexy thing, a part of what we do, but I appreciate things like this and this conversation because I think more people are beginning to understand how important it is. Right. And so you have to have the interoperability. I think people would say that, but you have to have it in order to do this stuff that is really, really essential, which is running the AI models and doing value-based care and everything like that. But the more that we can appreciate sort of where we are today and where we need to get, and this is why I applaud you for having me on today. And I do thank you for that because this is how we enable all that stuff, and it's important. And so even me, I'm like, I like to get passionate. You can probably tell around what I do, and I now have a real passion around data interoperability because of what it can lead to, and I think that's really kind of cool. And there's so much, like, this is the time. I can't say that enough. Like, we are in a really interesting time in space where there's so much focus on this because there's so much potential. And so I just love to keep the momentum going, and, you know, and again, just be able to enable and empower things that can really, really impact health.
Yeah, no, and I think that's a beautiful way of putting it. I think, you know, for those of you who can't tell, I am a big sports fan, and you know, one of the things, you know, John Wooden always talked about was the fundamentals, and I think one of the fundamentals to AI, you know, and for those of you who don't know, John Wooden was a coach of the UCLA Bruins many years ago, fantastically successful. So if you want to think of Bill Belichick or other coaches, they all talk about the fundamentals, and to do AI and modeling, predictive analytics, population health, you need data, you need good data. And you need it in the right places. So I think, you know, that's all very important. So really appreciate you coming on, Trip, and really appreciate all of your comments.
Yeah, thank you, Jeff. And for those of you who are not sports fans, you know, should be sports fans, but if you're going to become a sports fan, you must be a Boston sports fan. So
absolutely,
you know, I got to say good luck to the Celtics and the Bruins. And you know, we'll talk about the Red Sox and everything else later, but those one, they're in the fight right now. So go Bruins, go Celtics.
We may have to make some offline wagers with some of our New York friends in case the Rangers and Knicks get a little further.
I know that's going to be ugly. It's going to be fun, but it's going to be ugly. So
yes. All right, Triple. Thank you very much. I appreciate it.
Yeah, thank you, Jeff, and have a great weekend.
You too.
Okay, bye-bye.